Yeah, and so just to maybe dumb it down for a dumb old orthopedic surgeon like me, what you're saying is, if you have a pattern which is associated with insulin resistance, typically high triglycerides, perhaps low HDL, you can have variable amounts of LDL cholesterol, even normal to low normal amounts, and still be at significant risk. And that's why we see a lot of cardiologists and cardiothoracic surgeons say, hey, I see a lot of people on the heart attack, going in for CAS and open heart surgery that had normal LDL cholesterol. And that's that cohort, correct?
Correct. And this kind of has tentacles into a variety of communities. Cholesterol is just a marker of the particles that carry them. The particles are the real problem. So if the amount of cholesterol in a particle is never the same, you can get situations where people's cholesterol values don't look so bad, and yet it's missed the boat. The problem is the number of bad particles is still quite high. And this feeds into a correct but controversial narrative, and that is that cholesterol is not always a very good marker of cardiovascular risk. That's a true statement. And so when people look at that, they say, well, how do I understand that? Does that mean that cholesterol doesn't matter? Does that mean that LDL doesn't matter? Does that mean that the measure I'm using, LDL cholesterol, is imperfect, and therefore I need a better measure so I don't get put on the wrong track? So this is, I think, an important analytic conversation, what we measure and why what we measure matters. So I don't have a problem with people who look at the cholesterol hypothesis, quote unquote, as imperfect. That's true. But what's not is the case is that the number of particles is irrelevant. It's very relevant. And the key here is how long have people been exposed to a burden of particles that would increase risk of blockage in their arteries. The longer, the higher, the worse.
So we could conceivably make an argument that someone had a higher cholesterol but better insulin resistance, and actually have less risk than someone who had really bad insulin resistance and slightly lower LDL. It just depends where those numbers overlapped, and I guess, and I certainly, when we look at the ApoB, or it's ApoB 100, ApoB 48, it seems like there's a variable amount of these different particles, whether they start with the chylomicrons, which are like triglyceride rich, typically all the way down to the LP little a, which tends to be predominantly cholesterol. Correct me if I'm wrong on that. But, those things can variably increase or decrease and not be completely concordant with just the cholesterol measurement. Is that fair to say?
Right. So the ApoB pool is interesting because you said that there's an ApoB 100 and ApoB 48. That's true. What's curious is that ApoB 48 particles, chylomicrons, contribute about 2% to the total ApoB pool. 98% of the ApoB pool is the B100 particles. And of the entire ApoB pool, 90 to 95% of the ApoB pool are indeed LDL particles. So when we kind of unpack this, there are many types of ApoB particles, but the lion's share are LDL, and a very small amount are the B48 that come from the intestine. So as a result, we're basically saying the simplest answer is the more ApoB containing particles, the more risk we have. And just physiologically, the lion's share of those are B100 and their LDL.
Yeah, and so if we can say, I think it's a very fair statement to say the more the more ApoB particles you have, the more cardiovascular risk factor you have, all other things being held equal. Now, not all other things are held equal. You just mentioned things like insulin resistance modifying that risk. I have a question to you about, there's a particle size, and then there's the actual vessel itself. And the blood vessel itself, the artery, is going to be increasingly at risk for I guess I call it vascular stickiness, for lack of a better term, based on the proteoglycan content and the glucosamine tails that are on there. And there's things that modify that. I did a little, fair bit of research on this, and I see the proteoglycan content can be modified by certain drugs, antihypertensive medications, diabetic meds, calcium channel blockers, and certain nutrients modify that. So is there some, can you say that we can change the qualities of the vessel themselves by diet, by exercise, by medications? Is that a fair statement?
To some degree. A lot of the proteoglycan that is part of the atherogenic process is the matrix protein in the wall of the artery. So if we think of an artery as a tube, And keeping the tube open is important. In an arterial system, there's a pulse pressure. And so when there's a higher pulse, it kind of stretches a little bit. And when the pulse pressure goes down, it relaxes a little bit, but it doesn't collapse on itself because we have this matrix in the wall of the artery, proteoglycans. And that basically forms a web, almost like a catcher's mitt, right? And so the more densely this web overlaps each other, it forms a tighter surface that can trap these ApoB-containing lipoproteins. So when you look at just the architecture of an artery, as it's in a straight laminar flow, there is a lesser weaving, if you will, of proteoglycan than at branch points or areas of turbid flow. And where you have that, you have a greater density and overlapping of proteoglycans. That is why you basically, in most cases, see atherosclerosis begin as a focal disease process. Spots here, spots there, where there is a greater density of this network of proteoglycans that can trap ApoB-containing lipoproteins. Now, affecting that is something that has got some early research. We're not really sure exactly how much we can affect that, but there are some things that can affect proteoglycan in the artery wall. The chief driver, however, is the number of particles entering in the first place. The more in circulation, the more they enter the artery wall. The more they enter the artery wall, the more there's a chance for them to be retained. And so this idea that particles that are retained are the ones that can contribute to atherosclerosis is an old theory that started back in the 70s and 80s called the response to retention hypothesis by Dick St. Clair and others. And that's been shown to be a valid part of, but not a complete explanation for atherosclerosis.
Yeah, we talked to you, and I'd mentioned like my sort of numbers. Like I said, I had I think an LDL cholesterol, 130, 140, not ridiculously high, but certainly higher than a classic person would like to see that under 100. And some people much, much lower depending on your overall history. And, other mitigating, like we talked about some other mitigating factors. We know that, like, for instance, VO2 max predicts atherosclerosis. So if you have high VO2 max, you're less likely to have atherosclerosis. I'm a guy setting world records. I've got a pretty good VO2 max. And I've had a CAC score, which was 0 also, which, again, when we look at the net balance of this, how interested are you in imaging? Do you think that, because, my question is, let's say I go on because there's, obviously you deal in cardiovascular disease, and there's a lot of things that happen in medicine. There's arthritis, there's mental health disorders, there's cancer, there's autoimmune disease, there's gut issues, which I see in this whole community. I can tell you there's people in here that if you told them that your risk for cardiovascular disease has definitely increased, some of them would deny it. Clearly, some would say, I feel so good, I can't believe it. And others would say, I don't even care because I feel so much better. My quality of life is so much better that I would rather feel like I do today and not have this miserable, crippling mental health disorder and take my chances. That's there, and I think we can't ignore that. But what do you think about just a belief that we should just lower cholesterol as low as possible? There's people out there that certainly believe that. They think everybody should be on a statin, everybody should be perhaps on a PCSK9 inhibitor. And do you have any concerns about the conflicts of decreasing your risk for cardiovascular disease, but perhaps diminishing quality of life or increasing your risk for other things?
It's a great question. And I like the way you set that up because, we are a total being with lots of other factors other than just what's happening in our vessels. And that's, I think, critical. I hope I do that with my patients, that, we have what we call a shared decision-making conversation, which is the totality of them as well as whatever their cardiovascular risk may be. So this kind of gets us into the topic we were talking about at KetoCon, and that is, how do you try to individualize your approach one patient at a time? There are several parts of that conversation. One you brought up is imaging. I think imaging is critically important. Let's take a patient that I see frequently. Somebody comes to see me for the first time and they have a history of numbers that aren't great. One of the things I'd like to understand is how long has that been the case? And I can't tell you how many times people are unaware of how long their lab values have been potentially bad. They just got a bad value. They got sent to me. So I really don't have any context of how long has this been the case? What's causing the abnormality in the first place? Should they be worried? The typical idea for most risk factors, be it smoking, hypertension, lipid disorders, is how bad for how long. The smoking is easy. People know when they started smoking, they know how much they've been smoking. So that has a dose exposure to it. And the same we think is true in general for ApoB containing lipoproteins. In general, the higher, the longer, the worse, with lots of mitigating factors. But if I don't know, if somebody comes to me with numbers that are not great, one of my first questions is, how are your arteries? Do you have plaque in your vessels? And if you have plaque, how much plaque do you have? If you have a very high plaque burden, especially at a younger age, a process has started that needs our attention. And that becomes the focus of the exercise. It's really not about what number I want to get to. What number do you have? It's, are your vessels showing me a disease presence that either we are unexpected or is expected? And so I do think imaging is one of the get out of jail free cards for some people. And I think it's a mitigator of how aggressive should I be for others. What do I do if I have a 70-year-old lady who comes to me, and this happened not long ago, saying, I don't want to be on a statin. I'm here for a second opinion. Well, who said you need to be on a statin? My doctor. The story was she had high LDL cholesterol. I asked, how long has it been that way? She said, you're the first doctor to ask. She pulls out a 3-ring binder, starts flipping back, and it started 5 years prior to seeing me. I said, well, has anybody checked on other reasons why they could be high? She had a TSH of over 50. She had hypothyroidism. We fixed her hypothyroidism. Her LDL melted back down to normal. Oh, and by the way, a coronary calcium score of 0. And I said, so good news is you don't need a statin. And a 0 means you're actually in really good shape for your age. And you can opt out of a statin for at least 5 more years. You can get 5-year, increments of checking a coronary calcium if you like. But this is the case where knowing a little bit more about the patient, digging a little bit deeper, looking at the vessels, looking for reasons why values can be abnormal, and fixing root cause, I think is a better approach than what used to be the idea that statins weren't a product to be worried about. Just put it in the drinking water as low as we can go for everybody is a good idea. Obviously, that has limitations.